Omphalocele is also called as exampholas. So this is how the whole thing, and you can see that the swelling is attached to the umbilical cord. So it
Yes.
invariably arises through a defect in the umbilical region. Right? Whereas gastrostasis is always lateral. It comes on the lateral side of the abdominal wall and doesn't have the covering. Whereas here you can see there is a covering in that you are not seeing directly any bowel outside.
Yes, sir.
So this is about the history. The person who described this, he was a French barber surgeon, Ambroise Paré, has described that. And then the other condition, gastroschisis, was described by Wisting. So mostly both these conditions are common in this, and they always compare these two conditions. And the actual defect is because of the umbilical defect, you can see this the umbilical cord. So the umbilical cord will be always attached to the swelling in omphalocele, whereas in gastroschisis that will not be the case. And it is a central defect arising at the umbilical ring. Defect may be very small or big, and if the sac is amnion, cotton jelly and peritoneum and umbilical cord inserts directly into the sac at a vertical or lateral position, and it may be containing intestinal loops, or it may have other organs like liver, spleen, bladder also, as you rightly said. And the diagnosis can be made by the presence of alpha fetoprotein in the elevated in the mother, where you will have other. If this is there, you have to think of neural tube defects and duodenal or esophageal atresia, which are very important. So the testing of maternal alpha fetoprotein is very, very important. And this condition can be diagnosed in the antenatal period itself by fetal ultrasound at 14 weeks of gestation as a confirmatory test. And coming to the neonate, I thought I will have to give you a little bit of knowledge on that to write. So the definition of neonate is any child who is 4 weeks old after birth or 44 weeks of gestational age. That is the definition of neonate. What are the common issues in neonatal anesthesia? First and foremost, you have to try this thermoregulation. So neonates are susceptible to hypothermia because they have less brown fat and they cannot shiver to produce the necessary heat. So they produce only non-shivering thermogenesis. They can create heat or produce heat only from this brown fat. So they are more prone for that. The second reason is they have a larger body surface area compared to older children and adults. So more skin will be exposed, and that is the second reason for their becoming hypothermic. And third reason is generally any patient who comes and undergoes general anesthesia, they turn from homeothermic to poikilothermic individual. They will try to take up the temperature of the ambience of the area. So all the patients who undergo general anesthesia convert themselves from homeothermic to poikilothermia. So that is the third reason for their loss of temperature. So you have to take all precautions like as you said, warming the IV fluids, increasing the ambience operating room temperature to anywhere between 28 to 32 should be the ideal temperature for neonatal anesthesia, and warming blankets and warming lights all should be used. And the second important thing is they tend to become hypoglycemic. So glucose management is very important because they do not have a normal glycogenolysis or gluconeogenesis, and their glycogen storage is also very low. So they tend to become hypoglycemic even for a short period of meal per oral. So if you advocate meal per oral for a longer duration, or if they have some vomiting issues, then they become hypoglycemic much more faster. So what is the fluid of choice in neonates? What is the fluid of choice, Vidya? What is your choice for neonatal fluid? Maintenance of hemoglobin and volume.
Sir, crystalloids with dextrose sir, at 2.5% dextrose.
2.5%. Actually, it is D5LR. lactated ringer with dextrose 5%, which will be mixed, and then that is the thing to prevent hypoglycemia. And for maintenance, you can use either normal saline or lactated ringer without glucose, 10 ml per kg, as an intermittent bolus instead of infusion. Okay? And positioning, this is the third thing which you have to take care of. They have very thin skin, relatively very little fat stores, and they have very flexible and soft skulls which can easily bruise. So all these things have to be taken care of. So proper positioning and rechecking the position is very important. Coming to intubation and airway management, they are increased risk of hypoxia and they desaturate faster. And they have large head, floppy epiglottis, and anteriorly placed or highly placed larynx. So intubation may be difficult. So do not extend the head. Easier intubation is done by keeping the head in neutral position or even in a slightly flexed position compared to the older or adult patient. Now, this is the Ocean 789 rule, where the rule is used for introducing what is the depth of endotracheal tube you have to place inside the neonate's throat or trachea. So, according to this rule, if the child weighs only 1 kg, the tube should be at 7 centimeters at the gum. If the child is 2 kg, you add 1 more centimeter, 8 centimeter at the gums, and 3 kg, 9 centimeters. So that is what is called the 7, 8, 9. And normally neonates will not weigh, very rarely they will weigh 3.5 or 4. Okay? But normally their weight will be anywhere between 2.5 to 3.5. So this rule is ideal for preventing endobronchial intubation in the one lung anesthesia. The other method is you can add 6 centimeter to the weight of the baby. So whatever be the weight of the child, supposing it is 2.5, you can add 6, it will become 8.5. So you can keep it at 8 or 9, 8 or 8.5. That will not cause a one lung intubation. Now, what is the size of the tube to be used in neonates? That is again based on the weight. 3 mm ID uncuffed endotracheal tubes are usually preferred, and if the neonate is more than 1 kg weight, and if it is less than 1 kg, normally 2.5 uncuffed tube will be sufficient. Now coming to the cardiovascular system, neonatal myocardium is less compliant than adult myocardium, making neonatal cardiac output dependent on heart rate. So they are rate dependent children. The second important thing is the vasoconstriction response is very poor to hemorrhage. So they will not be able to tolerate blood loss. So you have to keep a very close watch on that. Maximum blood loss you can allow is, what is the maximum blood loss you can allow?
10% of the total blood volume.
So it is roughly will be about 30 to 40 ml because they are only both maximum 3 kgs. Now coming to circulating blood volume and blood loss, neonates have a circulating blood volume of 90 ml. But if they are premature, they will have 100 ml per kg. So you have to calculate the allowable blood loss before you take up any neonatal patient. So that is calculated by the estimated blood volume. So for example, if the baby is 2.5 kg, 2.5 into 90 ml. If it is a full-term gestation baby, you have to multiply 2.5 with 90, then you will get almost 180 and 45, 225 ml will be the estimated blood volume. Multiply that with the initial hemoglobin minus the target hemoglobin or the final hemoglobin divided by initial hemoglobin. So this will give you how much maximum blood volume you can allow to be bled. And the common thing is, do not wait if the surgeon is using the suction. Do not wait for the blood to reach the suction bottle. That itself will cause about 40 to 50 ml of blood loss. So in neonatal anesthesia, this is a very, very important point. You have to be very, very watchful to prevent even small amount of blood loss. Then respiratory system and metabolic oxygen requirements, the alveolar maturation is not complete at birth. In fact, the alveoli keep growing until the child is 8 to 10 years old. At the time only it becomes fully developed. And the neonates desaturate quickly and they take a longer time to recover because the airways collapse very fast and it takes time to open up the alveoli which has not been ventilated. So you have to be very watchful, and their oxygen requirement is also higher compared to the adult. So they require 6 ml per kg per minute. So all these reasons make that they are more prone for hypoxemia, and once they develop hypoxemia, they will develop bradycardia very fast. Probably that is the reason you mentioned about atropine. That is a very good medication to prevent this hypoxic bradycardia happening. Now coming to the pharmacology and drug metabolism, renal and liver maturation occurs around 6 months of age, so drugs have to be used with caution to prevent overdose. Now what are the investigations you want to do? CBC, urea electrolytes, coagulation profile, blood glucose, and you have to check the bilirubin, especially in neonates. Why? What is
They'll
the
have
reason for physiological jaundice may be there. So that has to be assessed by checking the bilirubin. You have to take test and abdomen X-ray, echocardiogram to rule out any occult cardiac pulmonary defects. And what is transitional circulation? It is very, very important point of neonatal anesthesia. What do you understand by transitional circulation?
So
If you
they'll
have to
have
mention in
patent,
all your answers.
they'll have patent fetal circulation sometimes. At 3 days, the ductus arteries will be patent.
Actually, functional closure occurs, but
Yes,
structural closure may take a
sir.
long time.
Yes, sir.
But functional closure occurs within 48 hours, isn't it?
Yes, sir.
If the baby starts breathing on its own, the
Yes, sir.
functional closure of PDA will happen. But in conditions during anesthesia, suddenly they change from the fetal adult, neonatal circulation to fetal circulation. That can happen, which is called the flip-flop circulation. So in utero, pulmonary vasculature resistance is high, and there is very little blood flow going to the lungs. And placenta is the main source of gas exchange for the fetus, as all of you know. But once the baby is born and it takes a few breaths, then the pulmonary pressures come down. Pulmonary vasculature pressures come down, and blood starts flowing through them, and the ventilation is the main method of gas exchange instead of depending on the placenta. Okay? So changes from the fetal shunts. There are 3 shunts which are there: foramen ovale, ductus venosus, and ductus arteriosus. Out of which this ductus arteriosus usually remains patent for the first 48 hours, but after that it starts closing by functional method. But the structural closure or asphyxia takes a longer time. So because of this possibility of the opening of these arteriosus, what can happen? During the first few weeks of life, if there is a pulmonary vasculature which is very reactive, and if the vascular resistance increases, then blood can flow from the right side to the left side, just like your allostetrology or other conditions where right to left shunt can happen, and suddenly the child may go in for hypoxemia. So this is what is called the transitional circulation, which is a very important point you have to mention in all neonatal anesthesia. So you have to make sure that you don't create a situation where the pulmonary pressures go beyond particular level. And so coming to the challenges in the anesthetic management, challenges unique to neonatal anesthesia and heat management, fluid management, nutrition, abdominal distension, infection control. In addition to the intraoperative, you have to prevent hypothermia, place the baby in warming mattress, attach non-invasive monitors, IV induction. Propofol is avoided because they don't have the mechanism to stabilize them. preferable to go for tapentone or inhalation with CO and oxygen. Avoid nitrous oxide because it may distend the bowel loop if they have the contents in the ampulla. Then muscle relaxant, you can use atracurium or supratracurium, plain ETT ventilation and control ventilation. Maintenance with oxygen, air, CO, again avoid nitrous. Single shot caudal block with pituitine 0.2%, 1 ml per kg can be given for intraoperative analgesia. And post-operative care, sometimes they have to be kept in neonate intensive care. Large defects, as you said, may require ventilation, feeding in minimal volume, 48 hours antibiotics. Hence, hernia which may be there if you are not able to close completely may be dealt after 1 year of the life of the child. Okay? So these are the points that you have to keep in mind for omphalocele. Okay?
Yes.
Right.